Okay, so kicking it off, my name is Sophie LaMarche. I'm a senior consultant with Bowling Business Strategies, and on behalf of BBS, Mercer, DMMA, and Doing Right by Birth, I would like to welcome you to the second webinar in our 5-part series that is led by Dr. Mishka Turplin and Dr. Kima Taylor, who will introduce themselves here shortly, along with Jill Gresham, who's joining us for today's session. I also want to give a special thank you to Brian, Sherry, and Alethea from DMMA and Trisha from Mercer for their support throughout this series. Like I mentioned, this is the second webinar in a 5-part series that runs through November. So you are welcome to attend any or all webinars. We are going to be recording each of them and sharing out the slides after the session. Today's webinar is the middle one here in this red box. It is part 2 of our holistic prenatal care sessions, focusing on barriers and facilitators to dyadic well-being, with a special focus on child welfare reporting and plans of safe care today. We do have one more webinar at the end of September on the 26th. That one will focus on birth in the context of substance use, and then one more session in October, and the last one in November, which will focus on the postpartum period. Please help us spread the word. You may notice that some of the statistics and policies we talk about may be specific to Delaware, since that's where our panelists are located, but the series certainly has information that is of interest to folks all over. So if you find today's session helpful or you are interested in future topics, please feel free to share this with your network. The link and QR code here will take you to the registration for our session on the 26th. But I'll put in the chat once I turn things over. I'll put in the chat the links for all of our remaining sessions. Just a quick disclaimer, the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of Bowling Business Strategies, the Delaware Division of Medicaid and Medical Assistance, or Mercer Government Human Services Consulting. And with that, I will turn it over to our panelists to introduce themselves and kick us off.
Hi, I can go first. My name is Dr. Kima Taylor, as Sophie mentioned. I'm a pediatrician by training, as well as a public health practitioner and co-founder with Mishka of Doing Right by Birth. Really have worked since medical schools to eliminate disparities and improve dyadic well-being outcomes, especially at the intersection of behavioral health and primary care. So I'm very happy to be here. I'll turn it to Mishka.
Hi, wonderful to be here. I'm Mishka Turplin, OBGYN and addiction medicine provider, and we've been worked along those intersections with Kima and with Jill for like decade plus. And I'd really like to welcome Jill joining us today. So please, Jill.
Thanks. Hi, everyone. Jill Gresham. I'm with the National Center on Substance Abuse and Child Welfare, where I'm a senior manager over our in-depth technical assistance program. So I work with state teams to really address the silos between the child welfare, substance use disorder, and court systems, and work with states to implement plans of safe care.
Okay, and I'm going to start us off. And ideally, I'm going to be able to move the slides, so we'll see how this works. But I want to start with our agenda today. It's kind of a packed agenda, but we ideally want to finish in the first hour with the content and then have Q&A in the second half hour. But we're going to do a brief level setting, review the previous webinar, then do a deeper dive on substances, talk about child welfare reporting in the dyad, and then go into in-depth conversation about plans of safe care, supporting in infants and new parents with substance use disorder. And then we'll have time, as I said, at the end for Q&A. So I'm going to do this first part, the level setting. Oh, there we go. So wanted to really kind of refocus us on why we're here today. And that's because comprehensive, much less culturally and linguistically effective treatment and medication are rare and unavailable for most pregnant people with substance use disorder. And really want to level set us on the equity idea, because the goal here is really equitable outcomes. And it's important to note that equity is not the same as diversity, equity, inclusion, though the latter is key. Equity and access does not necessarily lead to equitable outcomes. And equity and equity lens is needed in all areas: policy, practice, programs, development, implementation, all of it. And you can start in one area and spread. Don't get overwhelmed, start and then start changing other pieces. But this really requires changing the way we were taught and often changing the way we think. Equity is not a pull-out, not something you add on or tag along at the end, because many of our current policies, practices, and programs are embedded within equities. And so it requires being cognizant of that and reconstructing what exists. As I said, the key is equitable outcomes from our policies, programs, and practices. This requires the ability to collect data, know who you're collecting data from, and have that trusting relationship, assessing the data, disaggregating the data, looking at it, and then seeking to decrease and ultimately eliminate inequities and holding people accountable for that goal. Yep, it's hard, but it is achievable, and we have to achieve it for the sake of our patients with substance disorder and those writ large. So what is our goal? Equitable access to and outcomes from culturally and linguistically effective, community-based, non-punitive, person-centered health and social services that seek to preserve and support families, that support improved wellness for parent, infant, and dyad. And I use culturally and linguistically effective as opposed to what people have used, culturally competent, because I've worked in multicultural settings and you can't be competent. What you can do is be humble enough to continue to learn, to work in partnership with people so that your partnered outcomes are effective, and have that as your goal. I'm bilingual. I spent much of my time seeing patients in another language, and you can provide culturally, linguistically competent care that still doesn't get to the outcomes you seek to achieve. So it's really about the efficacy of our engagement. And so I wanted to start this conversation, and anyone who's ever seen me do a speech knows that I often quote this because it's so powerful. And want to say that we are really talking about centering the parent, the infant, and the dyad, improving those well-being outcomes in an equitable manner. And to do that, because of our past history around substance use, to do that, we have to change the way we think. And this says, I mean progress in the sense, the natural way in which learning something new requires getting rid of something old. Like how discovering that the world is round means that you can no longer hang on to the idea that you might one day fall off the edge of the earth. And now that you've learned that something you thought was true was never true at all, every idea you hold firm comes into question. And I want us to sit in that space where we come into question about the things we have been taught, which are often punitive, and really look at a new space where we are going to achieve really well-being dyadic outcomes that are equitable, that are centered on the dyad, the parent, the infant, and the two together, and really seek to have to rectify the idea that pregnant and parenting people who use substances have not received the care they deserve. So I'm going to now pass it over to Mishka.
Thank you so much, Kima. And last time, we really focused on opioid use disorder. And what I want to drill into now is talking about other substances. But some of the principles that we discussed last time completely apply. Primarily, the idea that treated use disorder improves birth outcomes. Healthy mother equals healthy baby. Chronic disease management of any chronic disease in pregnancy improves birth outcomes. That's true of hypertension, diabetes, and also of use disorder. And substance use is common. Here, these are data from the National Survey of Drug Use and Health, which looks at, sort of past month self-reported use, and almost 20% of people who say, yes, I'm pregnant, and yes, I used a substance, illicit alcohol or nicotine / tobacco in the past year or past month. And contrast this with almost any other health condition. This is more common than depression. This is more common than hypertension. This is more common than diabetes. And I really want to begin with alcohol because alcohol, of all of the substances to which people can develop a use disorder, alcohol is the one that's a teratogen that can cause birth defects. It's the leading cause of preventable intellectual disability in the United States. There's fetal alcohol syndrome, which is the birth defect. And then there's fetal alcohol spectrum disorders, which are not a diagnosis, but are a constellation of related syndromes. And many estimates of school-age children identify up to 1 in 20 have evidence of fetal alcohol spectrum disorders. And so that's a large population health burden. And I don't know the details around this in Delaware, but I know in Maryland, there was a specialty clinic for infants who were identified as being alcohol exposed, and there were about 5 a year identified. So a clear undercount of what the actual prevalence of exposure is. For many people who continue to use alcohol during pregnancy, they will meet criteria for an alcohol use disorder. And we have 3 FDA-approved medications for alcohol use disorder and several other ones for which there is a large evidence base of effectiveness. The 3 FDA-approved medications are acamprosate, naltrexone, and disulfiram. And gabapentin has an evidence base that's, I think, equal to naltrexone and to acamprosate. But most sort of public health messaging around medications for alcohol use disorder in pregnancy do not emphasize medications, in part because safety data are minimal and effectiveness data are actually lacking. There are people trying to sort of interrogate that assumption of no medication, because there's a clear risk of alcohol and a degree of unknown around the medication. So current thinking is that it's individualized, but I would encourage everyone to consider medications for alcohol use disorder in pregnancy for people with AUD, with the exception of disulfiram. That is the one that does appear to be associated with the effectiveness is lower than the other ones, and 2 is associated with issues. And this here is an article that sort of summarizes the state of the science for both animal, preclinical, and the limited clinical information. So alcohol is really the most consequential substance. And I would say the second most consequential substance is nicotine/tobacco. And I put these together because tobacco is clearly, the plant product, and nicotine is the psychoactive compound in tobacco. But there's many other ways you can get nicotine, especially today, through vaping, e-cigs, gums, lozenges, treatment stuff even. And so we group them together. And there's a huge literature on, smoking in particular and pregnancy outcomes, associations with ectopic, miscarriage, abruption, previa, preterm labor and birth. We know infants tend to be born smaller, lower birth weight, preterm, even stillbirth, and an association with sudden infant death syndrome after birth. The recommendations aren't as vague for tobacco, nicotine as they are for alcohol. But you should know that despite decent and rather extensive clinical trials, there is limited to no evidence of effectiveness of medications for nicotine use disorder or nicotine use in pregnancy. But this is probably in part an artifact of the fact that about half people quit or cut back smoking anyway. So it's hard to show an effect greater than the natural history of smoking. So care is individualized. Nicotine replacement, which include gum, lozenges, or patches, can be considered. And certainly in non-pregnant people is one of the primaries. But nicotine in and of itself is associated with some of these complications. So what you want to do is make sure that you're not increasing somebody's nicotine exposure through the administration of NRT. Bupropion and varenicline, which are both other prescription medications utilized in the treatment of nicotine use disorder, and are probably likely more effective and in a general population, in particular for women compared to men. So may have an effectiveness, in pregnancy as well. We know that motivational interviewing, contingency management, which I'll talk about a touch more coming up, are core, parts of behavioral support. And all states have a quit line and a website, and almost all in Delaware have special services and availability of telephone counseling for pregnant people who smoke cigarettes. So utilizing a multi-pronged approach that, can consider medication, consider behavioral health, and actually consider having the behavioral health be delivered, in part through the quit line. We talk about stimulants, and stimulants include both cocaine and amphetamines, and the one amphetamine we see the most is methamphetamine. Both of these have vasoconstrictive properties, which relates to some of the birth outcomes. The acute use of either of them can be associated with higher blood pressure, which can present as a hypertensive emergency or hypertension on labor and delivery. There can be an association with preterm birth or low birth weight. Abruption is rare and is only associated with cocaine. And just keep in mind that multiples of rare events are still rare events. So even if something doubles or triples the risk, if it's a rare event, it still remains a rare event. And none of the stimulants are considered teratogenic. There are no FDA-approved medications for the treatment of stimulant use disorder. There has been decades of research looking into this, and probably hundreds of millions of dollars spent both in drug development and in clinical trials, which means that we actually have a decent amount of evidence across a spectrum of different, medications that have been studied. And many of them have a modest effect. Lower, these medications don't work as well on the level of the population as opioid use disorder medications or alcohol use disorder medications, but there is some effect. So care can be individualized, and these are some of the ones that have, been studied for the different, naltrexone's been studied for methamphetamines, psychostimulants have been studied for both, topiramate for both, and bupropion for cocaine addiction. To my knowledge, there's no clinical trials looking at any of these within pregnancy, so care would be individualized and medications can be considered, in particular for people who aren't responding to behavioral support. The core parts of behavioral support consist of motivational interviewing, which probably should be called motivational listening, but it's sort of a reflective practice with the person that you're serving. And the behavioral intervention that has the largest evidence base is contingency management, which means like having an incentive for something. Sometimes it's for negative drug tests. Sometimes it's for, adherence to clinic. The incentive can be cash, it can be vouchers, it can be you can accumulate tokens that then can be, turned in for baby seats or stuff like that. It's a large area of research, and of all of the behavioral health supports, the one with the strongest evidence base across all use disorders and including in pregnancy is contingency management. Finally, cannabis. Cannabis is one of the older plant-based, medications that appears in pharmacopoeias across, the globe, cross-culturally. And cannabis was utilized and during the so-called patent era of medications when turn of the 20th century. And in particular, those medications were sold or marketed explicitly to women. And perhaps the most famous sort of medical cannabis consumer was Queen Victoria, pictured here, who was prescribed cannabinoid oils, on behalf of her royal physician for the treatment of menstrual pain. And today we're in this sort of explosion of cannabis attention, criminalization, legalization, medicalization, and an attention continues to cannabinoids and cannabis related to women's health. One thing I really want you to know is how we mislabel and consequently misinterpret drug testing in cannabis. Delta-9 THC is the psychoactive ingredient in cannabis. It is metabolized sort of out of our biological compartment, within hours to maybe days, depending on kind of what data you look at. Carboxy THC is an inactive metabolite, and that's the one that's tested for. And carboxy THC can stick around in the biological compartment for weeks or even months, in particular in heavy, people who had heavy use. So it's completely possible for somebody to say, I last smoked cannabis, in the second trimester and still test positive at birth. And some of this is because the drug test itself is mislabeled. It says THC, but it's not. It's actually carboxy THC, which is inactive, not psychoactive, sticks around for weeks, months, and we actually do not know what the clearance is in pregnancy. That's never been studied. So finally, when we think about cannabis, there's a whole topic. We could spend hours on this. But I think the important thing to keep in mind are there two things. One, many people, and likely increasing, are using cannabis for the self-treatment of symptoms, some of which are pregnancy specific. Nausea, vomiting, insomnia, anxiety, and etc. That emerges to some extent out of legitimate medical mistrust and legitimate mistrust of sort of the safety of, especially long-term safety of prescribed antiemetic medication. We know more about the developmental outcomes of in utero cannabis or cannabinoid exposure than we know about the long-term developmental outcomes of antiemetics like Phenergan or et cetera. Second is some people who use cannabis in pregnancy will meet criteria for a use disorder. We're not sure exactly what the proportion is, but in the general population, it's somewhere between 5 and 10%, and that number might be higher in pregnancy. So when somebody's using cannabis, it's important to assess them for whether or not they have a cannabis use disorder. I think we need to also assess them regarding drug testing and reporting and understand ourselves, like how to better interpret drug test results. For people who meet criteria for a cannabis use disorder, there are no approved medications. And the core treatment really rests upon comprehensive care. So prenatal care helps birth outcomes in period. And, the use of behavioral health interventions, such as, motivational interviewing and contingency management. So with that, this is just one citation that I wanted to share with you that really summarizes what I just went through. It's an article that reviews the current literature by substance around substance use disorder in pregnancy and at birth. Thank you. And back to you, Kima.
Thank you, Mishka. And the thing I want really for people to remember as they listen to what Mishka is saying, that you've done this before for other chronic concerns, right? Be it hypertension or someone comes in because they have a seizure disorder or diabetes. You assess, you weigh the risk of providing medications versus not. Often the medications are provided. You watch the person during prenatal care and ensure well-being outcomes. So it's important to note that we're changing the way you think about substance use. Everyone says, okay, well, we know substance use is a chronic disease, but we don't treat it that way, like the way we treat others. And what we're asking you is the world is not flat. We're going to change the way you're thinking in order to provide this holistic care. Another way that substance use is quite different than those other chronic concerns, even though we say we know it's a chronic concern, is the interaction with child welfare and the child welfare reporting consequences. And I really want to stress it's the dyad. So often we say we're going to report to child welfare for the child's sake, or we're going to report to child welfare for the mother's sake. But this isn't isolated parent or isolated child. We really need to care for both and for the family as they define it and for the community. It requires a different way of thinking because, as we know, there are inequities baked into what we are currently doing. There are disparities at the outset of referrals, as well as long-term poor outcomes that are inequitable. So disparities at the outset of referrals, even as people say, well, we're going to do universal testing, and often they do drug testing. Drug testing is not a test for parenting, for substance use disorder, or for child abuse. But so say you do a verbal is the test, and you do a verbal screen, there's still disparities when you do that universal of who gets referred. And then there are disparities in terms of long-term poor outcomes if both are the parent and the child are not seen as important. And if they both don't receive equitable access to and outcomes from culturally and linguistically effective, community-based, evidence-informed, non-judgmental health and social services. And I put the Delaware data down to demonstrate that there are disparities and we need to change the way that people are thinking, because at the end of the day, we go into this work because we want wellness and we want to work with people. And ideally, I am fairly certain that we don't embrace inequitable outcomes. And so we really need to look at the systems to see why we're creating those. And as I said, it really is the dyad. And one thing I think it's interesting, often providers, if someone has a heart concern, they'll send them to the cardiologist, ask the cardiologist what happens, they'll follow up, they'll bring the person back. Child welfare, honestly, we're taught in medical school, send them to child welfare and hope that works out, right? There's not that follow-up. And so I want to have a little conversation about that follow-up. Because even though we often send people to foster care, which again, disparities in that, the outcomes are not necessarily ideal. Without appropriate support, foster youth often have unstable housing, lack of employment and job training, justice system involvement, and lack of healthcare. So that outcome, that long-term outcome, needs to be reconsidered, and we need to change. The world is not flat. We need to change the way we're thinking. Because right now, Black and Indigenous youth are overrepresented in foster care. Black youth with experience in foster care have 20% lower odds of achieving similar employment or substantial earnings compared to white foster care youth. And that's in a spectrum of inequities that already exist. And Hispanic youths with foster care histories have 10% lower odds of achieving stable housing compared to non-Hispanic foster care youth. And again, that's within a broader system of inequities that exist. And I do want to state, using Black and Hispanic, those are based on the wording used in those articles. So I want us to learn and try something new, including dyadic well-being. I'm not going to go through these, but these are a few, as Mishka mentioned, other articles about how to think differently about the well-being for both. And then really recognizing that the American Academy of Pediatrics really recommends pediatric prenatal visit during the 3rd trimester as an important first step in establishing a child's medical home. As a pediatrician, I always have to mention this because often that's not talked about in prenatal care, but it is important to establish and help the parents establish that relationship with the pediatrician. And this requires interacting with a pediatrician that provides culturally linguistically effective care, a pediatrician that understands substance use disorder, understands many of the metrics that Mishka went through earlier. So it's not just a path off, it really does require having that relationship and understanding the relationship and the ability to refer to someone that you trust. So with that, I'm going to pass it on to Jill Gresham. And I have to, and this is something you'll say, I have these little things. And one thing I do want to mention is that I'm really excited to have this conversation about plans of safe care. But again, this is something we do. All infants should have plans of safe care. Bright Futures, which is something that I even printed it to show you, something that pediatricians use in order to improve outcomes. About handouts that are essentially plans of safe care. Let's include pregnant and parenting people who use substances and what we do. We know how to do this. So I'm going to pass this over to Jill.
Thanks so much. So as I mentioned earlier, I'm here today with the National Center on Substance Abuse and Child Welfare. If you haven't heard of us before, we're jointly funded by the Children's Bureau within the Administration of Children and Families, as well as SAMHSA, which is the Substance Abuse and Mental Health Services Administration. My actual employer is Children and Family Future, so we have been the contractor for the National Center since its inception back in 2002. We also are the National Family Treatment Court Training and Technical Assistance Provider, so we've worked with hundreds of family treatment courts around the country as well. So I'm going to talk today a little bit about the Child Abuse Prevention and Treatment Act and plans of safe care to support infants born exposed to substances, and just a little piece of data to kind of kick us off into this discussion. When we pull this data nationally or by any individual state, we see this pattern over and over again, which is that infants are outpacing every other age group in going into out-of-home care. So this is adoption and foster care data, or AFCARS data, that states collect and pass up to the federal government. When we see these very young kids going into care, it generally is attributed to substance abuse, mental health, or potentially domestic violence going on. So we wanted to, recognizing that substance use is an issue that really can't be solved by child welfare alone. I want to talk about opportunities within the Child Abuse Prevention and Treatment Act and plans of safe care. So the Child Abuse Prevention and Treatment Act, or CAPTA, is a really broad piece of legislation that's been around since the 70s. It impacts all different areas of child welfare practice and provides funding and grants and other things. When we talk about it, we're talking about a very specific short passage that specifically talks about infants born prenatally exposed. That first appeared in 2003. There was an amendment in 2016, and then there was a more significant amendment that happened in 2016. Sorry, there was an amendment in 2010 and then a significant amendment in 2016. The big thing that happened in 2016 was they struck out the word illegal. They essentially said that infants who were born affected by substance abuse, withdrawal, or fetal alcohol spectrum disorder needed to have a plan of safe care. And previously it had said affected by illegal substance abuse. So it broadened the population of infants that needed to have a plan of safe care to potentially include parents who were on prescribed medication, or parents who were receiving something like methadone or other medication assisted treatment. It did a couple other things, like it kind of upped the ante in terms of data that states needed to report up to the federal government. Prior to 2016, there was a recognition that states weren't fully implemented on the plan of safe care. And so increasing the data expectations was a way to sort of move another step towards compliance. It also broadened the impact of the plan of safe care. And historically, the plan of safe care was really focused on just the needs of the infant. And just like Dr. Taylor was talking about, that need to focus on the dyad, that was sort of the restructuring of the plan of safe care, really is now supposed to address the health, substance use disorder treatment needs of both the infant and the effective caregiver, whoever the caregiver is for that infant. And then it required states to essentially build monitoring systems to see how effective these plans were in terms of their implementation. So when you think about, well, what are plans of safe care and what's happening in my state, there's a fair amount of variation that happens in terms of implementation from that sort of federal legislation to the state level. So the first thing is, what does it mean in your state to be affected by substance abuse? And so a lot of states have done some work to figure out who actually needs a plan of safe care and who doesn't need a plan of safe care. And then some states have said, some infants might need a plan of safe care, say for a prescribed medication or for maybe some marijuana use earlier in pregnancy, but that doesn't really rise to a child welfare intervention. And so then states have to decide if they want to create different pathways for different populations of infants. So one pathway that essentially goes to child welfare, and they do what they've always done, and then also do the plan of safe care, and then a second pathway that maybe goes elsewhere. And that's sort of the third question, was if we have this other pathway that's going somewhere else, who's going to oversee it and implement those plans of safe care? And then finally, what's the actual plan of safe care itself? The federal legislation doesn't give us like a template or much to go by. So states have created their own versions of plans of safe care. So if you're not familiar with a plan of safe care, it's a little bit different than a child welfare services plan or safety plan. Oftentimes people hear that safety and think it's the same thing as a safety plan, but it's different because it goes beyond sort of the safety needs of the child and talks about sort of the wellness of the family at large. Similarly, it goes beyond an SUD treatment plan, which really generally focuses just on the parents to talk about sort of parenting and children and the needs of children. And it goes beyond the just sort of that health focus of a hospital discharge plan. I like to think of it sort of as a conglomeration of all three of those things, and that in a lot of ways, it's still a living document that changes as the needs of the family change. Who needs a plan of safe care? Like I said, this is going to look different, right, from state to state, depending on how they define it, but it tends to fall into one of these three buckets. In some states, they have said, this is the federal language. It says affected by substance abuse, healthcare providers, we're going to let you determine what that means in our state. And so essentially the state just restates the federal language within their legislation. And then sometimes hospital systems will do some defining, but and sometimes it's left up to healthcare practitioners to determine at birth, do I believe this infant was affected? So that's sort of bucket number one. Bucket number two is based on the toxicology test, usually of the mother and or the infant at birth. And then the third option sometimes goes back into pregnancy, so that if there was substance use earlier in pregnancy, that might mean that there's a plan of safe care required at birth. So why consider a notification pathway? So lots of states, like I said earlier, have created these sort of secondary pathways. And historically, child welfare might get a call about an exposed infant and screen out, and those infants and those families didn't necessarily get services, and then they might pop up again, 2 or 3 or 4 years later. So the idea with the notification pathway is that it's not necessarily a call to child welfare. It's something that gets routed to a community provider. It's voluntary. Providers engage with and work with the family and hopefully get them those additional supports that they need to, again, sort of avoid any kind of a crisis that might come up down the line. So just to give you an idea of what these pathways look like in different states, and I wish I could be like, this is exactly what's happening in your state, but I know we have a kind of a group of folks from different states on the line, and they just do look different. This is sort of the typical way that they've always worked, which is that the healthcare provider identifies some kind of substance exposure they call child welfare, and now child welfare sort of engages with those families. In a lot of states, it's child welfare working with them, even if they are kind of low risk or only need a plan of safe care. And in that case, they might send them on their assessment track, or do voluntary services and just essentially provide that plan of safe care, but it's all done within child welfare. The second track, and I think Delaware, I know Delaware has sort of a split system, but I know part of what they're doing is similar to this, but that it starts off the same way where the healthcare provider identifies that there is some substance exposure that's happening and it goes to child welfare. And then child welfare makes a determination, yes, there's some risk happening here, we'll keep this family and do that plan of safe care work, or no, there is no risk happening here, so we're gonna send this family to a community provider and they're gonna do the plan of safe care. So I know years ago, Delaware actually spun up a request for proposals. And so they have a contracted provider who owns that sort of secondary notification pathway. In other states, it looks different. I think in Rhode Island, I think they had public health that's doing it. I'm working with Wyoming and they are having their early intervention system takes those notifications. So it just sort of depends on which state, kind of who holds those notifications. The third option moves everything, the decision-making upstream to the healthcare provider. So the healthcare provider sees an infant, there might be some kind of exposure, and they say, gosh, there's some risk here that I'm concerned about. I'm gonna send this family to child welfare. Or they might say, I'm really not seeing risk here that warrants a child welfare response. So I'm gonna send that family directly to that notification pathway, to that sort of community health provider. And so it looks like that state that comes to mind is Washington State, where they actually have this pathway out to Help Me Grow. I know in Delaware, they also have this pathway that kind of reroutes back to the medication assisted treatment provider if it's a mom who delivers while she's on MAT, rather than going to child welfare with the exposure. So determining what's going on in your state might take a little bit of footwork from you. I think the first thing to understand is, what does your state law say? So some states have legislation about who needs to be reported or notified in different situations. But a lot of states are handling this in policy and through guidance. And so you won't find an actual piece of law about this, but you can find some state guidance, and it's usually housed within child welfare pages or Department of Health pages, whoever is sort of overseeing the initiative. Sometimes it's called the CAPTA page, or sometimes CARA page, the Comprehensive Addiction and Recovery Act page, or sometimes just the plan of safe care work that they're doing. When states are doing something and providing guidance around this, and particularly when they're doing notification pathways, they're usually offering other tools. So Connecticut and Washington and others have created some nice decision trees to figure out, should I report this, or is this a notification that goes directly to the community provider? And then in some cases, they have some assessment tools to help with figuring out some of those pieces. So really quickly, I'm going to go through a couple of national maps with you to give you an idea of states that have legislated this. So again, some of these states are doing notification work, but it's held within policy. But this gives you an idea of those that have legislated this. So this first map is where states require a report for prenatal exposure. So there may be some exceptions to this. For instance, in Washington state, there isn't a report required if it's a prescribed substance, but other exposure requires a report. This doesn't necessarily mean it's an automatic screen in, but in these states, exposure means you must report to child welfare. And you'll be getting these slides, so you'll have time to kind of dig into them a little bit more. So these states in green are those where exposure is really codified as child abuse or neglect. And in these states, when a report, there's a requirement for that report, and when the report comes in, there's going to be some kind of engagement with the child welfare system. So potentially an open case or voluntary services or something that's going to happen due to that exposure in this law. This is a combination of the two that we saw, just to get a sense of where there's required reporting versus that codification of abuse and neglect. And then finally, this is the map that really looks at states that are legislating that secondary notification pathway. So that says, if there's exposure, we want this notification to happen, and it should go to the community provider. I'd also note that in several of these states that have these secondary notification pathways, the data collected is de-identified. So child welfare in some of these cases doesn't have person level data on the families for the notification. They're just getting information that the notification was made, usually the substance type, and that they were connected with services. So one last map just to give you the whole overview with each state and what they're doing. Again, a reminder that some states are handling some of these pieces through policy. So they might not be reflected on here, but might have a notification pathway functioning. Okay. So very quickly, just talking about building a supportive response during pregnancy, the birth period, and beyond. So I know we've talked a little bit about the need for universal screening during the prenatal period of time. So there's that opportunity for identification and engagement in services. I'd also just want to make a plug for people with lived experience, so peers or mentors. They really are the pros at engagement, and especially during this period of time, to just help with addressing any issues of shame that might come up for that parent who's going through this, because they're with somebody who's been through this process before. They're just really fantastic. And we use mentors a lot, particularly in emergency room and overdose situations. We're not tending to use them as frequently during this prenatal period, and I think it's a missed opportunity. During the birth event, just that opportunity to build those plans of safe care, to have that dyadic response that we talked about earlier. And then that beyond period of time, Dr. Triplin often calls the 4th trimester. So how do we maintain supports there through home visiting, ensuring that families get connected to early intervention? Oftentimes kiddos get initially screened out for early intervention services because they're too young to like notice any kind of delays, but it does pop back up and they oftentimes miss that opportunity for rescreening. Lots of states are starting to look at implementing prenatal plans of safe care. So essentially these collaborative responses during the prenatal period of time. In many situations, we know that these kids are coming, so it makes sense to start the process prenatally. This isn't required by the capital legislation, but it really does make sense to avoid that crisis moment at delivery. So we're seeing states like Wyoming is starting to implement the Children and Recovering Mother model, which is out of Vermont, where they're building collaborative teams that are then supporting pregnant women as soon as they're identified to connect them with services, try to reduce use and get them ready for that infant to come. They're held together and allowed to communicate through ROI, so confidentiality, multi-system confidentiality forms, as well as memorandum of understanding to be able to share different information. So all that's happening in that prenatal space, right, to be able to prepare for the birth event. So if this has sort of spiked your interest a little bit about how to get involved, I think one way to think about it is, are you integrating verbal screening tools to understand if there is substance use going on for the families you're working with, not only within the healthcare sphere, but also in the home visiting sphere as well. If you've been confused by any of the plan of safe care chatter today, reach out to your child welfare office. They know about these mandates. They're probably doing something. If you can't find it on their website, they should be able to talk you through what they're doing. If you're curious about, like, maybe we want to integrate a plan of safe care template, I have many, many versions of them, from one page to this really fantastic binder model that comes out of Houston that they call a recovery resume that mom sort of carries around, and it becomes an advocacy tool for her at birth if child welfare does need to get involved. So that's sort of practice opportunities. There's lots of policy opportunities as well. Really, there's so many teams coming together at like the state level to start to build out these practices. And the CAPTA change happened in 2016, and states implemented an initial process, but most of them are coming back to the drawing board to say, you know, we're in compliance with the federal mandates, but we want to build something that's more effective for families. And so this is a really kind of prime time to be involved with that work. So there's probably some kind of a collaborative team happening in your state. And if you're somebody that comes with a voice of lived experience, again, we'll just plug that. We need more voices at the table who have been through it themselves, so we can understand and learn from their experience. So I have a number of resources that I won't go through to allow just time for discussion and questions. I saw some questions coming in, but you'll have those resources, and they're just all different pieces from the National Center that you can find on our website. But Sophia, I'll turn it back to you. Or is it Dr. Taylor?
Thank you so much, Jill.
Mm-hmm.
That was awesome.
Thank you.
I think now we can like open it up for like Q&A. And I think people can go either put questions in the chat or in the Q&A itself. And Sophie, has anything come through?
There's a few questions in the chat, I think, for Jill.
Let's see, I see one about each state has different rules. Oops, it just bumped on me. For the safety plan, is there a template of recommendation for an equitable plan, recommendations for an equitable plan? I don't know if I could say specifically recommendations on an equitable plan. I have a number of different plans that I'd be happy to send out to folks who are interested in that. I think the one that's been probably most effective is the model out of Houston, because it's really built together with the parent and her providers. So she essentially brings it to her appointments together, you know, and they sit down and fill it out together. So has the health and mental health and SUD pieces all integrated and anything she's doing to prep for the infant to come.
Can I just add to that?
Uh-huh.
I don't think we really have centered equity in many of these plans. And something Jill noted, one, it is important to have diverse voices of people with living experience. But the other piece is we often say, well, we're going to achieve equity, so we're going to treat people as individuals, but we've seen that does not actually work by the outcomes that we have. And so it really does require interrogating, gathering data, getting the demographic data, which is not easy because people are righteously not necessarily going to give all their demographic data. Sometimes it's not self-reported. In some states, you're not going to say your sexual orientation, right? But it does require confidential data that's disaggregated and assessed, because even as we do these kind of universal verbal screens, we have to understand, are the outcomes and paths that people being led to effective? Are they culturally linguistically effective? Are they having equitable outcomes? And we don't really have that data, nor do we have the data to be able to then hold people accountable. And that doesn't always mean shutting down offices, right? That means, how do we work together to figure out how we're going to provide those culturally linguistically effective services? It's like that rapid testing that used to happen. There was this program called Dyadic that was used in substance use to get people into treatment earlier. And it's this rapid testing. Let's get everyone involved in the systems, test it. Did it work? Nope. Got to try something else. Did it work? Nope. And it really does involve that kind of comprehensive working together, because I said the world's no longer flat in this world. We have to think differently and rethink some of these structures. And so when Jill was talking about that policy piece, I think that is a piece as people are working through what they're going to do differently, require the centering of equity, require the understanding that people have had different lived experiences. I showed you those stats. Different people are going to have their kids taken away at different levels, even if it's substance use versus not substance use, and what we're looking for and identify as a reason to take children away, right? So really interrogating the why, the paths they go through, the outcomes folks have, that should be at the early part of many of those conversations that you're having, and the ability to not only assess that data, but also mechanisms to hold systems accountable. And if systems continue to perpetuate the inequities, then yeah, sometimes some of those hammers need to come down, but it doesn't really exist in an effective way now.
I added in the chat a couple of questions that we had received from registration. And then, yeah, folks who are here on the line, feel free to keep adding your questions in the chat.
Yeah, and Sophie, I think there was one further up that was for Jill. Do they know the location of reporting? So if someone's de-identified with a notification, I think that's what it's referring to. And please correct me in the chat if I'm misinterpreting your question. But do they know the location? They may not know the name, but do they know the location?
Yeah, so typically they ask the hospital name. And some states might also ask the resident's zip code to get a sense of if they're delivering in a different zip code from where they live.
I'm also seeing a statement by Sissy. Sissy is on it in the chat, so thank you. But I live in a conservative state where families will lose their infants or will not be able to breastfeed if they are positive. We're going to talk about breastfeeding at the next conversation, but this as a whole, what you're saying is quite unfortunate. I don't know if Jill wanted to respond or Mishka, since I'm talking so much.
So in some states that we've worked with, sometimes plans of safe care have helped with some of these issues to create that pathway out to other services so that we don't see those families taken into the child welfare system. Obviously, we'd like to see kind of education, right, and support going to those providers as well, which I'm guessing Mishka will talk about, but just from that the plan of safe care lens, I think that's one of the ways that we can sort of support those families going out to the community providers that really can serve them instead of into the child welfare system.
Yeah, we will talk more about breastfeeding, but really briefly, like to me, the sort of prohibition of breastfeeding due to a drug test is like, has a resonance with, the automatic separation of an infant due to a drug test. And the similarity is that we know like the benefits of keeping, the dyad together. And but there's like some perception of risk which motivates like the separation. And that, that unknown somehow drives us cognitively more than the known benefit. And the same with breastfeeding. The benefits of breastfeeding to both, the breastfeeding person and especially to the infant are very well established. The risks of breastfeeding in the context of substance exposure vary a little bit by substance and all sorts of other things, but are not are not a absolute kind of, there's a balance kind of risk. And so it's the same sort of cognitive dissonance. I think and like just for today to reiterate for the perspective of cannabis, it's unfortunately not uncommon that people are being told not to breastfeed from that misinterpretation of the drug test result that makes the provider think that the infant is being exposed to Delta-9 THC, when in actuality, it's the inactive metabolite, unless that person is currently using cannabis. So that like, so we're making decisions based upon misinterpretation of information. There's like some questions around, like I wanted to get back to this and maybe we could all sort of talk about it, from the registration form, the latest data on development impact of dyadic separation due to child welfare involvement. I think the inverse, is actually, we have more evidence on the inverse of what the benefit of early attachment and on early childhood development are. That's like, well established globally. There was a National Academies of Medicine report from 2000 that laid out the science at that point in time very clearly, and only the science has only been strengthened. But one of the conclusions from that report was the fact that there was disconnect within sort of the federal and public health infrastructure in the utilization of this science. And I would say that conclusion still is true. We know what, we know what children need to thrive. And a lot of what we do is an interference, of that. So I don't know if either of you want to comment on like data on developmental impact of dyadic separation.
I think you said it well. I don't know that I have much to add.
I do want to add, completely agree with Mishka, which is why we work together a lot. I do want to add that we are not naive. We know that because of the past, many of these cultural and linguistic affective services are not available in the community. So this is a little bit of building the plane while flying. But as Mishka said, we know the science that dyadic, like parent as medicine, we often say in peds, we know the efficacy of that. We know that if someone does have developmental delay, yes, they need early intervention services regardless. And we know that as pediatricians, at family practitioners, other providers, that we need to refer them to services. And so as Mishka says, I think some of the issues, there's a disconnect between what we know, what we would do for other parent and infant diets, and what we're doing in this space. And what we're asking is for people to learn, to be able to understand the science that exists for all families and apply it in this space in a way that's going to really lead to equitable outcomes of family preservation, wellness, and well-being. But recognizing that there is, in fact, provider shortage. We live in a broader space of lack of equitable outcomes for many things, inclusive of maternal child health outcomes. And so that is why in the policy spaces, we need to include the population, and particularly, I would say, as Jill said, people with lived experience at all these different conversations that are happening, be it the early intervention conversation, be it the parent family dyad conversation around maternal health outcomes, workforce development, all of it. We need to include our population to ensure that they're receiving the services we know that they deserve in order to have those equitable outcomes and well-being.
And you know what you're saying makes me think a little bit about alcohol. Like as mentioned, a leading cause of, sort of preventable intellectual disability in the United States. There's the fixed, you can't undo the fetal alcohol syndrome, the teratogenic, the facies and stuff like that. That is fixed and immutable, at birth. But the bulk of the other symptoms are sort of what the people call like the sort of the secondary symptoms, conduct disorders, behavioral issues that emerge, a little bit later as as infants or children, enter really into the school system. And there's a large body of evidence that early intervention reduces the severity of those secondary characteristics. And CDC, like, sometimes early intervention seems like this giant lift. And, there's a workforce piece, there's a referral piece, and it just seems like this big thing. But CDC actually simplifies it. And really, in order, for those infants to thrive to their full potential, it's being raised in an environment that's supportive and stable and devoid of violence. And that's really it. And so it's yes, the workforce is helpful. Yes, there's a lot of other things, but that sort of stable context, and I feel like if that, though, stability devoid of violence is beneficial for the substance that has the greatest measurable outcome, negative outcome, it's of benefit for all of the other substances that have minor to modest sort of outcomes. And actually, if you think about it, it's of benefit, like early intervention and supportive services for the dyad, for the family, for the community, are things that are not necessarily or categorically substance specific or substance use disorder specific, and are actually interventions that can be of use to everybody. And when we think about like how to address the enduring and deep stigma and discrimination that people who use drugs in pregnancy in particular face, I think the one way that we get over that is by not linking services, not having our response be substance specific. If our response is universal to support, attachment, to support the dyad, to support the family, that's actually a response that is beyond, the discrimination.
Yeah, I really want to second and third that comment. And it gets to one, the Surgeon General just recently put out a Surgeon General report on the fact that parenting is hard and has always been hard. And so it's really, again, it is understanding how to provide services. And as I mentioned before, pediatricians, we have plans of safe care, right? How do you create, and I apologize, maternalistic, but fundamentally, how do you create a hug around people so they get through that parenting is hard period? And that can be and should be universal and helps to create that stable environment. Often in the US, we expect people to do things on their own. A lot of times it requires partnership. People of money may already have that. Some people who don't have money already have that. Others need those supports, and how do you build those in? They can be by service providers, they can be offering respite, they can be by group parenting classes. There are myriad different ways that we have figured out how to provide and care for people, whether they use substances or not. And this is really important because even the topics we're talking about, we talk about how many people have fetal alcohol syndrome. I know as a pediatrician, there's a lot of people who have fetal alcohol syndrome, don't have the obvious facies and go through, right? How many people use drugs? We did the screen. They may start it using after. They may have lied on the screen, right? So you don't actually know the population that you're serving because often you haven't built that trust. So just having this comprehensive set of responses for all people and recognizing and understanding and retouching on these conversations over and over again in prenatal care is going to be really important.
Yeah, and to stay on the fetal alcohol piece, it's been such a difficult area for so many states in terms of identification and support and implementation of plans of safe care, because they rely on testing at the birth event rather than that relationship building during pregnancy to have conversations about potential substance use. And so a lot of these kids go sort of undiagnosed until later in life, when they could have been getting these services and supports throughout infancy.
Yeah, it reflects this, like, I think, false overemphasis on drug testing. Like, you can look for alcohol in urine, but it's only in the standard, assays we use don't. And if you were to, you'd only find it like within hours of use. And so it illustrates like how our over reliance on drug testing biases what our response is actually away from like the exposure of greatest population health consequence. And screening and talking to patients and stuff like that is a far better way of assessing any substance use, and alcohol, like, especially.
Just moving down the chat, you guys have, I think, touched on this a little bit, but someone had asked, how can you encourage medical and SUD providers to collaborate care for the best outcomes for patients, parents, and infants?
Hard, but you got to get them communicating in some way. I mean, I think that's one of the foundations of the work that we do with states, is to get people from different systems in the same room, like having some conversations to start to build trust. Oftentimes systems really have no idea what happens sort of behind that registration door, behind the intake. It's all sort of a mystery to them. And even just starting that conversation with kind of what's happening and what are we doing and how do you refer and what happens if you can't get anyone on the phone, some of those really like primary relationship building pieces can then lead to more kind of regular information sharing and then collaboration. You're like not probably going to jump straight to effective collaboration without doing the relationship building piece of it first.
Yeah, I agree with that. I also think, though, there needs to be accountability, right? We don't have those relationships. One, I want us to caution in saying medical and STD providers. I know that's the way that it has been, and then mental health is over here, but we really need to talk about health and wellness and all of the providers together who are working to make that happen, which may include doulas, substance use providers, peers, right? So who needs to be at that table? Make them be at the table, and then try to use some of the tools we have to force it. So some of that is looking at perhaps value-based outcomes, right? If you have a value-based outcome and health-based, and I often like to say outcome-based payment system, because sometimes you focus on value, people are just trying to save money. But outcome-based system, you can, one, invite the people that you know need to be at the table for the wellness. So that can expand that definition of provider. You can talk amongst yourselves about what those outcomes need to look like in order to have those equitable outcomes and well-being outcomes. Because it's not just, we spend so much of our time in US around abstinence or not. It is not just that. Right? It is not even just about the substance use. It's also about the diabetes and hypertension, because again, we have maternal health crisis writ large, depression. What do those outcomes need to look like? Are you paying for those diverse services and for those equitable outcomes? Are you collecting, disaggregating, analyzing the data? Be held accountable for doing that and assessing it. And again, not slamming someone if their data isn't ideal, but being able to say, what is the performance improvement plan we can use to get there? And some states like Philadelphia has done some work around maternal child health and accountability around equitable outcomes, inclusive of the behavioral health space. So there are people out there. We need to use the levers that we have, because goodwill works to a point, but people are exhausted and busy and scared. Like with COVID, things were falling apart and COVID is still here. So how do we incentivize support? If you don't have all the information you need, how do we provide the education to ensure that you can get there? But then also the data assessment, sharing, and accountability that'll help us to actually get there. And if we don't get there, we regroup, start again, and try again. And if certain places are consistently harming patients and others, then yes, they need to be held accountable, and that may be negative consequences. And so getting people in the room, absolutely, and then doing something. And again, I go use outcome-based systems instead of value-based outcomes because we focus so much on money savings. We want outcomes and people well-being. And so inclusive in this population, like what does that child welfare interaction look like? Are they having positive outcomes? Are they equitable positive outcomes? And if not, what, like all of the partners need to be at the table. And when you think broadly about outcomes that you want to see, it broadens who's at the table. And if you have a system that allows for that different contracting for the people necessary to be there, inclusive of peers and others, it can give some hope.
Yeah. And to sort of add to that, this idea of like, how do you get to collaboration? We're going to talk more at the next session about mandatory reporting. But I just want to say that the one of the problems with mandatory reporting is it offsets responsibility of care from the health system that really can provide care to the child welfare agency, which can mandate services, but in and of itself isn't a behavioral health provider. So there's something about that process of making a report that leaves stops us from actually providing the care that the person and the family needs. I really I think I want to return briefly to plans of safe care or family care plans, because to me they illustrate like a possible path that serves the function of providing that holistic care that you were talking about, Kima, within sort of an existing lens of like policy and hospital practice. And and thinking about what and really ideally, like the plan shouldn't be just uniquely only for people like who use drugs, can be for like everybody, but it begins the same way that SBIRT or like behavioral interventions were developed around substance use and use disorder. They apply actually to all health states. You can use brief interventions when you're talking about like adherence to antihypertensive medications or to decision-making around contraception. There's nothing unique about that framework that's drug specific. It was developed in that space, but it actually applies more broadly. And actually somewhere the plan of safe care, you can does as well. But it becomes a way that the critical thing is like, whose plan is it? Is it the child welfare agency's plan? Well, then it might be wielded in a punitive way. It might not be supportive of a person's recovery, of attachment, of early childhood development even. But if it's a plan that's developed in collaboration with the person and it's her plan and it reflects her, like specifics, then as Jill mentioned, it can be a tool and even like an example of empowerment. And the binder that they take with them to all their visits that demonstrates their really like their recovery journey. And specifically, I think what we could do in this space around that, somebody mentioned multidisciplinary in the chat, and that's spot on. I'll say what collaboration looks like should look different in different places, depending who the champions are, depending who the actors are, depending, and they need to be supported. But thinking beyond the hospital, one resource I think we underutilize when it's available is early Head Start, which people who are pregnant can get access to. And I don't remember the number exactly, but it's something like 5% of people who are early Head Start eligible actually receive a referral, much less a follow-up from the referral. So we have systems that work that are adjacent to, but not super well connected to prenatal care and birth, that we need to build those pathways more. And the plan of safe care can become a mechanism, trying to implement or trying to figure out how to put it into practice as a way to create those connections between healthcare providers and the other social support services that are truly helpful.
Talking more about outcomes, I don't know if any of you can answer this, but someone in the chat asked, have there been publications of CPS positive outcomes after being connected at birth? And what analytics are they using?
I want to just take a step back. Like, it's a good question. And what we're going to talk a little, we're going to continue to talk about this. But like, I want to acknowledge like that, that there is, child abuse does happen. Child like severe neglect does happen, and it's real, it's rare, and I think it's within the health professional and health system responsibility to assess and respond and report and separate. There are circumstances where like separation is necessary. But I don't think that substance use in and of itself, or having a substance use disorder, is child abuse or is cause in and of itself for separation. And so the literature is mixed from this perspective, because yes, so there, if you were able to, and you sort of can, like look at the instances in which the child is being beaten at home and removed, there is benefit for that. But we can't, but stuff gets mixed, and it's unclear, and so so I think in those extreme circumstances, yes, and in the other stuff it's harder to see. There have been examples of, like, this is more local, of child welfare agencies that have been much more successful at getting people, access to even to housing, to other sort of like formed, made those connections. Those totally exist. And then there are other examples of where like those connections really don't happen. People are given a list of phone numbers or a pamphlet or something, and there's not the, the action on the part of the agency as much.
Yeah, can I add to that? I think Mishka's right, but I think also through this whole conversation, you've heard there be like, well, we don't really have data. There's not enough data. And partly that's particularly in the space around substance use. We decided on a punitive path and don't collect for moms and particularly young people, often for any drug, forget substances. We don't do a lot of testing and outcome work because we're scared, right? We're like, that could hurt the infant, that could hurt the child. So some of this, I think, gets to, and you'll see that I'm really about this outcome thing. I think another piece of that positive outcome question is we have to decide what those are. We have to come together, inclusive of people impacted, and say, what is it that we want to see? The child welfare system, like the healthcare system, overworked, underpaid, focused, sometimes, often not allowed to be in the correct place. So what are the outcomes we want to see, and how do we create systems that will recreate system that will achieve those little positive outcomes regardless of what someone touches, and making sure, should they touch it, that they are the right people to touch it. Like Mishka says, I'm a pediatrician, I've seen true child abuse, and it needs to be removed. So it needs to touch a system that's still going to have those positive outcomes. But what is that defined as? Even for the healthcare system, we do a very poor job on what is it that we want to see. We got stuck for so many years on not using drugs, having the infant taken away, not breastfeeding, all these things that you're like, well, there's more. We're not quite there. So I do think as a society, and getting to that collaboration, we need to talk and really talk about how we want to see and define outcomes, both progress, process outcomes, and absolute outcomes, how we're going to achieve equity in those spaces, and who needs to come to those collaborative circles in order to achieve them.
I think I've caught all of the questions in the chat. If there's anything else folks want to ask, now is your chance. Otherwise,
I had one other small piece. I also, this is a work in progress. Do not let, I think sometimes we're giving all this information, it scares people to start. You'll make mistakes. We've all made mistakes. Half the reason I do my equity work is the things I've done awry, right? But you learn from them so you don't keep making the mistakes. You ask people, but we got to start, and we have to start together, and we have to be humble enough to listen and move forward, because in the end of the day, we really do want to see those equitable outcomes. So we are not here to say, don't do this, do this. Like, let's work together, and let's work humbly to achieve the outcomes that we want to see. None of us are perfect, and none of us got it get it right all the time, right? Let's do more good.
And it doesn't have to be perfect to start. To piggyback off that, I think oftentimes we want to set up the perfect program. We don't want to launch until every piece is in place, but yeah, get it rolling, get something on the ground and tinker.
Yeah. And also, like, it's the outcome is important. Like, you know, the content of the plan of safe care is important, but the process is also really important. And without a good process, it doesn't matter really what the outcome is. So, and there's a localness to it, which it leads to a vagueness in these sorts of exchanges sometimes. But finding the group of people who care, starting, you know, where you can, having, you know, creating dialogue across, you know, the hospital to some other agency, you know, and having, thinking within, if you're at a birthing hospital, like interrogating your, you know, drug testing policy, and you know, coming up with, you know, an alternative, and that process in and of itself, you know, is important, because that's the work that we do. And so I just to echo what you were both saying, like, it's like, yes, the outcome's important, but don't forget, don't de-emphasize how to get there is, like, actually the journey.
One more question in the chat. With adverse childhood experience research and the negative outcomes from that, how do you determine where to draw the line between protecting the dyad and endangering the child?
I mean, so I'll start just because I think ICWA, the Indian Child Welfare Act, which was enacted by Congress, I might get this wrong, 78. And it was a response to the fact that a lot of Indigenous children were being separated and adopted out of culture. And in many ways, for federal law, it lays out most clearly, I think, the parameters of separation. And they are, is there an imminent risk to the safety of the child? And is there something that the parents are doing that is directly, you know, related to that imminent risk? So, for example, like, you know, the child is being beaten and one of the parents is beating the child. Like, that would be like an example of that. And then sometimes too, and have you tried other things first that didn't work? So those would really be the parameters. Is there an imminent risk? And is there behavior, parental behavior, that is, you know, contributing to that imminent risk? And have you, like, and you know, and it's not working. And so in the context of substance exposure, use, etc., like that rarely exists, and probably wouldn't exist solely, you know, in the context of substance use. But at the same time, we need to provide support for people. I think sometimes by just being like, not a report means, or, you know, means no provision of care and help and services. And as Kima mentioned so well and cited the Surgeon General's, like, recent report, like, parenting is hard and people need help and support. So I think when we have opportunities, you know, to provide, you know, help and support, like, period, those should be provided. So just because I wouldn't say separation is needed in this context, does not mean at all that that family can't benefit from you know, the holistic supportive services that exist and all of us want to provide.
Yeah, I really want to push that second one, that holistic supportive services. We always want to have these dichotomies. Yes, no, it doesn't exist. It doesn't exist in this space or any other. And even around the adverse childhood experiences, you want to make sure that that separation, the place you're sending, is not going to recreate adverse childhood experiences, right? Well, I had this one patient who, they did the ACE testing, the child reported that the parent used drugs and the child was removed, but then the child had just tremendous guilt and bad feelings, right? So it's murky. It's really murky. And being able to work with families and provide these services and cultural and linguistically effective services, listen to what's needed, understand what protections can be brought. What if it's, you're having adverse events because don't have food? What services can be brought? Is it SNAP? Is it these other things? Really doing those, not just doing those assessments, but having the partnerships that you can act on them, work in partnership with the parent and child to understand that they're getting them is going to get us to a better place. But we have to understand, and it's hard. But there aren't dichotomies. There aren't, well, you had 5 ACEs that were positive, we need to remove you. Oh, well, you had this and that, right? And other people will attest to how hard it is. And so how do we have these conversations? I think another space is having the conversations. The nice thing I think about multidisciplinary teams is you don't have to be the only one to answer that question, right? You can ask the other people on the team, like, what should we do? How you have a better relationship? What are you hearing? And so really, I think a lot of what we're saying is the whole way we approach people needs to be different. And the whole way we listen, even as Mishka said, motivational interviewing should be motivational listening. The whole way we listen to people needs to be different. And then we can build up systems that can afford people the supports they need, regardless of their income, race, sexual orientation, gender, disability. Like those are going to be somewhat idealistic, individual, but we can provide people with the diverse services they need.
Okay, I don't see any more questions and we are approaching the end of our time. So I just want to say thank you to our panelists, Jill, Kima, and Mishka, for your time and sharing your expertise with us today. And thank you to our participants for joining and engaging in the chat, asking questions. We really appreciate your time as well. I will share the slides and a recording of today's session in the next day or so. So you can expect to see that in your inbox shortly. And then I'm going to put in the chat again a link to our next session. I really encourage you all to join us if you're available on the 26th, because we will dig deeper into some of the topics that we started to touch on today, like breastfeeding and mandatory reporting. So you can expect to learn more about that then. There is the registration link. And again, just thank you all so much. Have a great rest of the day.
Thank you all.
Thank
Bye.
you.
All right. Bye.